Hello everyone, my name is Cindy Lopez and today I will be presenting my individual presentation topic on the drug Herceptin. What is Herceptin? Well, it's actually a brand name for the drug trastuzumab. Trastuzumab is a monoclonal antibody and the drug binds to the human epidermal growth receptor 2 positive protein or HER2 plus. This is HER2 protein is involved in cell growth found in some cancer cells. And then trastuzumab inhibits the ability of HER2 to send signals to proliferate cancer cells, while also stimulating the immune system to seek out and target cells that have high levels of HER2. There are a few different cancers that can use trastuzumab. It is most commonly used in breast cancer treatment, but it can also be used in stomach adenocarcinoma and gastroesophageal junction adenocarcinoma. Here I've provided a cartoon that gives you an idea of how trastuzumab works when inhibiting a cancer cell. Again, like previously mentioned, it is a monoclonal antibody that belongs to the family of small molecule tyrosine kinase inhibitors. Trastuzumab binds to domain 4 of the HER2 protein, and then this leads to the inhibition of cell proliferation. Within the cell cycle, trastuzumab disrupts the M phase of the cycle, altering the cell's ability to divide. For this presentation, I was tasked to find a research article that uses Herceptin in their study. Here I present trastuzumab-induced human cardiomyocyte damage through the Notch2, JAK2, STAT3 pathways. The first question asked was what key questions were asked by the author for the figure. I read in the article that they questioned if trastuzumab induced cardiotoxicity through these pathways. And what was the experimental design? Well, they purchased some Herceptin from the Shanghai Posh pharmaceutical company. At their facility, they had human cardiomyocytes in stock, and they thought out these cells and cultured them regularly using DMEM. The viability of these cells were assessed using the MTT method, which measures for cell metabolic activity. And then they stained the HCMs with dyes, which would later be used to check for apoptosis in these cells. Here are a couple of figures from the paper. Figure A is testing for the HCM's viability as they increase the dosage of trastuzumab. Notice here that the higher the dosage, the less viable the cells are, with a significant decrease in cell viability when treated with 250, 500, and 1,000 milligrams per liter of trastuzumab. In figure E, the graph represents the apoptotic activity of the cells treated with trastuzumab. Both the control and vehicle groups, or CON and MED, had significantly less apoptotic cells than the group that was treated with trastuzumab, or the TRA bar on the graph. The way they determined this was by staining the cells with a PI fluorescent staining and then checking the numbers to see which one had the highest level. I was also tasked in coming up with two questions in relation to the drug Herceptin. So I came up with these two questions. What are the components in trastuzumab that caused human cardiomyocytes to become more apoptotic after exposure to the drug? And is it possible to treat breast cancer patients with a lower dosage of trastuzumab over an extended period of time as to not expose cells with the higher dosage of the drug and cause decreased viability of myocardial cells? All right, moving on. We know that there are many disparities amongst cancer patients. I will talk about two today in my presentation. One that I came across while researching is that Black women tend to have an increased chance of dying from breast cancer compared to white women because of socioeconomic status, social injustices, inadequate health insurance, or a lack of access to health care. Here I provided a graph from the article, Effects of Socioeconomic Status and Race on Survival and Treatment in Metastatic Breast Cancer. The graph is a Kaplan-Meier survival curve, And you can see here on the graph that women of low socioeconomic status, SES, had a less median survival than women of high SES. They typically lived a little longer, basically. And the same can be seen in the median survival between black women and white women, with black women having a median survival of 1.8 and white women having a median survival of 2.5. Here I provide another disparity. I will be discussing how non-English speaking cancer patients can face many challenges due to language barriers. As a matter of fact, there seems to be a sort of bias towards non-speaking patients as I read through the article titled Hidden Disparities: How Language Influences Patients' Access to Cancer Care. They did a study where they documented how many patients were given their next steps of treatment over the phone. Those who spoke English well had a higher chance of being provided next steps than those that spoke Spanish or Mandarin. You can clearly see from this table that for non-English languages, people were not provided next steps more often than given their next steps. So how can the US tackle these disparities? Well, I want to focus more on the whole language barrier issue. There have been studies done using lay workers, which are members of communities that are usually trained to educate people on the importance of taking care of their health. These lay workers are usually trusted members of a community and have been linked to influencing higher number of women to get screenings done to look out for breast or cervical cancers. We can see here that these lay workers talk to patients more on a one-on-one basis, and they are able to help patients overcome fears that they may have, clear up any confusion, educate, and just overall help women seek out preventative measures that could potentially save their lives. Having people do screenings on a regular basis allows for doctors to ensure that there is no bigger looming problem, and if a problem does arise, they can tackle it sooner than later. On this table taken from Effectiveness of Cultivando la Salud, a breast and cervical cancer screening promotion program for low-income Hispanic women, you can see that the groups that had any lay workers talk to them, the intervention group in the middle, had a higher chance of coming back to the doctors for a follow-up in both of the cohorts. 40.8 versus 30% in the mammography cohort, and 39.5 versus 23.6 in the Pap test cohort. Thank you so much for listening to my presentation today. I hope you guys learned something new. And here are my references.